Well, actually, what happened is I get, because I've been to the course before, I get, I think it may be under grant. Let me just check. So, because here we go. I just got and here's the meeting that they're advertising.
Wow.
And that I don't know if you ran across the name Yehuda Handelsman. So he runs this whole thing in California. It's all insulin resistance. So I learned about polycystic ovary syndrome.
Oh yeah, that ties in. Yeah, I was aware of that.
Non-alcoholic fatty liver disease. Okay.
Epidemic.
Yeah, and all of that stuff they cover.
Wow.
And their new thing that I haven't had a chance to search the literature on is the kidney as a control of blood sugar.
Yes.
And that's and they bring in these guys. They also, the last time, I haven't been there for a few years, they actually have a cardiologist that's interested. And what the cardiologist does is Dopplers of the carotid artery, measuring the intima as a sign of what's going on in the coronary arteries.
Yeah, the CIMT, but it's loose. It's broadly correlated, but I think
but
it's a very easy measure.
Right.
There were some debates around CIMT versus calcification, but I think CAC is the kind of the gold standard.
So I had a patient. I'm an ear doctor. Okay, so I look after inner ear disorders. So that's my field. So I had this patient. He has this high cholesterol. And I said to him, we should get your coronary artery score. So he gets it done, and it shows he's got significant there. So I said, okay, take this to your doctor. So it just so happens my doctor's a cardiologist. He looked at it and said, forget about it. So then 2 years later, I get this call from him. I'm across. My office was across the street from the hospital I practiced at. I'm in the coronary care unit. I'm having quadruple bypass surgery tomorrow. Just wanted to let you know. I should have followed up with what you said. But I'm just an ear doctor, What do I know compared to this cardiologist?
This is part of the problem, Wow. And there's so many cases. The same in Ireland. It's the same. In fact, my sponsor is battling cardiology in Ireland, and they have dismissed the documentary got made on the power of CAC, and there's anyway, the first 2 or 3 chapters cover that whole crazy situation, But the mortality curves for CAC are extraordinary. I've never seen any. As an engineer, this guy rang me up, this multi-millionaire guy, and he's talking all this stuff. And then I went and I said, So I went and looked it up, and I went in 20 minutes of looking up for CAC. I was familiar with calcification, but I never dug in because I'm more interested in root cause. I couldn't believe the mortality and the advance per year. That if you have a score of 1,000 or 0, obviously a guy with 1,000, way higher risk. If you follow them for 6 years, the people who have 1,000 initially, I don't know, did you ever see the study? It's unbelievable. The people who had 1,000 originally have the same risk as 0 guys once they don't progress, which makes sense, but they have the exact same mortality curve, and it's perfectly normal. The guys who have scores of 80 but who progress more than 15% a year, the mortality curve is worse.
Right.
And the 1,000 guys who progress more than 15% a year, they're all dead in 3 years. They don't even get to the end of the study. So if the fire is alive inside, they're the most extraordinary curves. I'll send you them. I just could not believe that. So someone who has very high calcification, if they do the right thing, stop the fire, they're fine. And in this study, they were all on statins, and they simply split them by advance more than 15%, progress less than 15.
Yeah, but statins are just kind of a
mitigator.
Yeah, I mean the lifestyle is the more important part.
Absolutely.
That the statins kind of just make the numbers look better, but that's not really doing anything.
Exactly. And this expert team split them just by progression. They couldn't give an answer as to why. We treated them all the same. Some of them progressed and they died like flies. Some of them did stop. It worked. And they're talking about response to statins. The reality is, of course, some of them may have lost weight and cut down their carbohydrate. They could have dropped their insulin resistance. Some didn't. The ones who didn't died. Anyway, But you were so this whole conference.
I have a colleague who's in a nursing home with dementia, and his whole thing. He was also an ear doctor. And his whole thing was he would see his first patient in the morning at 4 in the morning. And he'd run 2 staffs through till 4 in the afternoon, which meant he was getting up at 2:30 or 3.
Oh, that's crazy.
And now the stuff just came out. I've been following it anyway for the last year or so, because that was my observation, that I thought his dementia was related to his sleep patterns or lack of sleep patterns. So this just came out this week. That when you go to sleep, the brain gets detoxified. And
Absolutely.
you need to have that thing, and the things that it detoxifies are the precursors that produce dementia.
Exactly. Yeah, that's it. Although, the only problem with that one is it's a harder one to manage. If enough science to know what to eat and the biometrics to watch, you're in great shape. The only one I'm a little lean on is the sleep one, just by necessity.
Right.
But still, what I do is I target mornings I sleep in, and I make sure I'm not too lean on it. And I believe the glucose metabolism is affected as well, isn't cortisol is affected, and
so the average person sleep-wake cycle, it comes out between 5 and 6 in the morning, cortisol.
Yeah, and when you lose sleep, I think that's why some people put on weight. Some people lose weight when they're stressed. There's a whole myriad of different things around the sleep thing alone. Never mind the rest.
Yes, and one year when I went there, they actually did. They have studies they've done on animals that hibernate. So they've already looked at what's going on to their glucoses and all that stuff.
Yeah.
So that actually came out of one of these insulin resistance meetings. So
which is another facet of
Yeah. So yeah.
the whole thing. It's hard to. It's all interconnected. That's what makes it so fascinating. I mean, it's almost all interconnected to everything. The cholesterol with the insulin, the omega-3, omega-6, we won't get into that, but the bizarre thing is, on the one hand, and you might have just glanced through Reeven's Insulin Resistance versus Mortality.
Gerald Reeven is a big guy at this meeting.
Oh, which makes sense, of course, yes.
He's always there, and and he's like the godfather of the meeting, so I know him very well.
he is, oh God, he's an incredible guy. And he basically kind of characterized and defined the metabolic syndrome around in the late 70s, wasn't it? They were putting together.
Yeah.
And there was one other major name as well who was attributed to, I forget, but his study in there, now it's a small study, but statistically it is valid. Small sampling theory with 200 people taken, non-diabetic, apparently healthy, middle-aged, insulin resistance properly characterized with the clamp, and then followed.
Yeah, so he was like a purist. So I got onto this because this same doctor who has dementia and some other people were talking about the fact there could be some metabolic factors affecting the inner ears of people. And I was a surgeon at that time.
Right.
So I only thought the answers to treat all these things were with surgery.
Yes, intervention out of the way.
And so what we used to go to like our major ear, nose, and throat meetings, and we'd always arrange to meet in somebody's hotel room. There's like 6 of us. That's all that we're interested in. So after a while, I decided, okay, so I'm going to start getting 5-hour glucose tolerance tests with simultaneous insulins on my patients. And that started, and so I have like 30 years experience with that. And I started to look at that, and actually it wasn't until Kraft in 1992, because I didn't know what the insulins meant. The first time I saw this huge insulin, I sent my patient because I thought they had an insulin secreting tumor in their pancreas.
One of those insulomas or whatever.
Yeah, right. And but I didn't realize your diet could drive that insulin that
remorselessly.
high. But it wasn't until 92, I think, when Kraft actually came out with his numbers, so you could begin to think when the insulin is normal and when it's abnormal.
The patterns, yes.
Yeah.
Amazing.
And so what happened is I would take my surgical failures and work them up. And then just by happenstance, there was a nutritional physician in Manhattan that I knew who had 2 nutritionists that worked with him.
Okay.
And so in early 1980s, I went to him with this idea, and I said, I said, they're talking about this, and I'm not sure if it's really going to work. So he said, okay, well, let's do kind of 50 patients. And I said, okay. He said, but they don't need to see me. You've worked all up already. We'll just send them directly to my nutritionist. They're under his supervision.
Okay.
And so we started to do that. And so all of a sudden, my surgical failures were doing better than I had anticipated they would get from the surgery.
Right.
So the next thing was, well, instead of operating on them first, why don't you just treat them this way first? And then that changed like the whole structure of things. As a matter of fact, for this insulin resistance meeting, I submitted an abstract, and I was calling the inner ear as the canary in the coal mine. So if somebody has ringing in their ears,
Tinnitus,
or if they're dizzy, all these things were showing up, but they refused to pay. But they couldn't understand it. As a matter of fact, insulin resistance people couldn't understand it. As a matter of fact, a few times they've asked me to submit papers, but I've moved on to all kinds of other things. I keep track of all that literature anyway. But that came abundantly clear, and then then I was making diagnoses of non-alcoholic fatty liver disease after going to this meeting and seeing what was going on with the liver function studies, and then I got into all the variations of what goes on with the insulin resistance syndrome. So, and it ended up being a big part of my practice. So I've retired from practice. As a matter of fact, I just actually sent a letter off. I have a research appointment, vestibular research, vestibular relating to the balance system, and so I've been doing. So I go there in the winter to escape here and do my work, and then the other times of the year we're on teleconference or emails with the team that I belong to back in Arizona. But this last time, things happened, and I had some initial discussions before I left in March about the possibility of actually, because I want to introduce these ideas, and so I'm having some discussions about maybe seeing patients a day or two a week to introduce all these ideas to them, because I think we could end up with a really good thing for the patients.
There you go.
So the other part, of course, is migraine, which actually there's a shift now occurring, and the guys leading the shift are some neurologists in Berlin at the hospital called Charité that think that probably 80% of migraine actually comes from the vestibular system, from the inner ear. Okay. Which is so not a brain-related thing. And so I've already spoken to the migraine neurologist, and she's interested in exploring this whole connection. And then lastly, my other interest is in the bone, the capsule of the bone around the inner ear. It's about 1.5 millimeters. It's the hardest bone in the body, harder than enamel on teeth. And the insulin connection with it is, I don't know if you ran across it in your reading, is there's a thing called osteocalcin.
Yes.
So insulin can affect osteocalcin, and osteocalcin can affect the bone around the inner ear. So I'm just hooking up now with a basic researcher in bone, because nobody's looked at the bone around the inner ear. So I'm looking to actually develop a center for the study of what's called otic. Otic refers to ear capsule disorders, and I finally found the right guy, and we're going to start doing some preliminary studies. Also, apropos of your inflammation and macrophage thing, is I was invited to a Department of Defense meeting in Virginia, must be almost 2.5 years ago. The largest amount of payout to veterans, U.S. veterans from Iraq and Afghanistan, is for ear noise from being exposed to improvised explosive devices. And the numbers are this. It's the #1 disability among veterans and 1 in 10 U.S. adults. In 2010, 744,000 veterans were receiving benefits for ear noise alone, amounting to $1.1 billion. Okay. Wow. And so what actually? I've been working on that, because what happens is when the ear gets exposed to a loud sound, you can actually measure inflammatory cytokines in the fluid of the inner ear.
Wow.
Okay.
You're making the connections.
Now I don't. Yeah. So I don't know if you probably didn't read about it when you were focused on the macrophage, but the macrophage has receptor sites on it. And one of the receptor sites on the macrophage is receptor activated nuclear kappa ligand. And when rank ligand goes into that receptor site, it converts the macrophage into an osteoclast. An osteoclast can eat bone.
Oh yeah, I know.
Okay, so when it eats the bone, it releases more cytokines to get into the inner ear fluid that are toxic to the inner ear. So I'm working on that as well, and it could well be, and I haven't really looked at the inflammation connection from insulin, but it's clear there's lots of stuff in the literature on the inflammatory thing, and TNF alpha is one of the major ones that are related to this cycle of the bone around the inner ear. So all of
I can just see all these threads connecting. And that's an advanced version, I suppose, of my early weeks. On the exact, so TNF alpha and all, I'm familiar, but I've been limited in scope. So like in engineering, I only go deep enough to get the central thrust. I can't go...
Right.
But I will at some point. But that's so you're linking then the inflammation to the tinnitus or tinnitus?
Yeah, okay. According to the dictionaries, either one's accepted. Either pronunciation. I say tinnitus. Some people say tinnitus, even in this country. So
okay.
So either one's acceptable. Yeah.
Well, I only heard, I think, possibly a few weeks ago, someone brought up about tinnitus being a sign of hyperinsulinemia, and I just thought that's interesting. But I had so much on. I left it at that. But migraines also, just interestingly, when I discovered all this and I immediately switched to low carbohydrate, I would have a headache every couple of weeks. I'd get a pill from the engineers at work. I never had my own. Every couple of weeks, maybe twice a month. In the 2 years since I switched, I've had maybe 1 or 2 headaches, maximum. Now I know that's N equals 1, it's not a RCT, right. But the dramatic change, I only realised after around a month or two. I just realised, wow, it just hit me. And there's a myriad benefits like that, but it's just interesting when you say the migraines tied, the tinnitus tied to insulin, to inflammation, to the osteoclasts. It's the problem is you almost begin to wonder if you take insulin resistance down to the floor. I mean, what does it not help? I know there's other things.
I'm actually a vitamin D guy too, because towards the last couple of years of my practice, because of my interest in bone, so I started to look at vitamin D. So I'm finding so there's a few things. So with a low vitamin D, what happens is you have not necessarily a low serum calcium, but you're not absorbing as much calcium, okay? Because you're not absorbing enough calcium, that triggers parathyroid hormone. Parathyroid hormone recruits osteoclasts in bone to break down the bone, to put the calcium into the circulation. What else does it do? When it breaks down bone, it takes out magnesium, okay? Because 80 or 90% of the body's magnesium is stored in tissue, and 50% of that is in bone. And so I come to Arizona, I've been doing it now for 5 years, and one of my colleagues, an audiologist, has been treating tinnitus with magnesium. So it turns out that, and he's been getting some really interesting results. So part of the problem is we're taking magnesium out of bone with low vitamin D. So I'm starting to work up these people, and they have secondary hyperparathyroidism. And you put them on vitamin D, and their parathyroid levels come down into the normal range. And then all of a sudden, so because of my interest in bone, I happened to be visiting a friend a physician who's a urologist in Rome, and we were having dinner, we were passing through one night, and he said, well, he can't, his knees are so bad, he can't do anything anymore. So I said to him, why don't you get a vitamin D? So it turns out his vitamin D was 20 and he had secondary hyperparathyroidism.
In animals now.
Within 6 weeks, his knee pain was gone. Within 6 months, the MRI changes on his knees reverted to normal.
Wow.
And so there's this whole, there's systems and feedback mechanisms, and then the bone actually, there's a new thing out that you may want to look up. There's a new concept that bone is actually an endocrine organ.
Right. I may have touched on that, but not in detail.
Yeah, and so all that literature is starting to come up now on that, and it's kind of interesting. And so my interest is on how these cells in bone actually communicate. There's a whole system of information that goes through bone. As a matter of fact, I think I have it on here, but people don't realize that bone as a living tissue is not just solid bone.
But isn't it built of protein essentially? Initially, all that I forget the name, the fibrous network, and then you recruit in calcium to stiffen.
Well, that's the osteoblasts build it up. But as the osteoblasts take on calcium, they mature, and then they become okay. So here is time-lapse photography of bone, and these things are called osteocytes. Is it still? Yeah, it's still going. So you can see them moving. So this isn't solid bone, and so what we're doing is we're gonna this bone researcher I've just gotten in touch with. Actually, he was here in New York. We're going to characterize and this is called the Lacunae network, and they actually communicate with each other. And I, on my aerospace side, because I'm interested in the microgravity and how it affects the astronauts and now in the space station, and they get osteoporosis.
Yeah.
Okay, and so I believe that the answer's in. Oh, and I was also interested in, because I've been going back to the evolution when we were fish, probably when we came on land.
Yep.
The evolution in the vestibular system in the inner ear over time.
Oh, right, okay. And we use vitamin D to incorporate calcium when we moved to the land. I mean,
among other things, yes.
Among many things into so many. I did a seminar.
So this is solid bone, time-lapse photography on solid bone.
And they're migrating through and across and communicating.
Yes, and these long things is called the cilium, and it actually has similarities to the hair cells of the inner ear. And so I'm actually working on a unified concept of how our nervous systems are set up, because I think there's another communication mechanism going on that I'm involved in some other things with my team, and we're going to be able to, I think, so we're looking to get some research dollars, because I need to get to work with an electrical engineer to get everything going.
Well, you've got your finger in every part of the pie, but it is ultimately it's all interconnected. I mean, even the vitamin D. I did a kind of a seminar. I didn't go too deep, but I went through all the correlations with death and disease, and I went through beyond bone health, and just explained all the stuff at a simple enough level. But the K2, isn't there? There's a thing as well with K2 vitamin. That if you're low on that, being very high in D can be counterproductive. But like you say, it's all a control systems feedback there.
Oh yeah,
the whole thing.
Feedback loops completely.
But that's what made me jump into it so massively when I realised all these feedback loops and how beautiful they were.
Oh yes, and they all work.
They all work. And back to the lipoproteins, everything works unless you go hyperinsulinic.
Right.
And then everything goes crazy. So you're involved in every aspect. When you were doing the insulin tests, the 5-hour glucose, your hit rate of people who are coming under pattern 2, 3, or 4 who were diabetes in situ.
So I would pick up a new diabetes once every 6 weeks. This is near practice. And there was another outlier one, which was a flat curve where the sugars don't change for the whole 5 hours, but you watch the insulin go up and come down. So one of the possibilities, if the glucose doesn't change, is it wasn't absorbed.
Yeah, okay.
But if the insulin goes up and comes down, it was absorbed, right? Yeah. So it was the system correcting itself in some form. So there's a very outlier group. I'm not sure if he even talked about it, but it was with.
I don't think I'm familiar. No.
Yeah. So we called it a flat curve, and it. Interestingly enough, the major things were, of course, the big fluctuations, and then whether it reached diabetic level or what you wanted to call insulin resistance. Sometimes the changes wouldn't occur for 4 hours. So some of the initial things that you'd expect were there, but the actual blood sugar wouldn't really drop till the 4th hour. It was kind of interesting kind of things, and then I actually have simultaneous blood sugars with hemoglobin A1C, and I found hemoglobin A1C wasn't all that good when you compared it to the glucose tolerance test, which were more accurate sugars. And I never really, in my mind, I never really classified them into patterns because I looked at them and I knew what they meant, but I never really put a pattern to it. But I would tell you that I'm only doing this on symptomatic people. I'm not doing it on people because I don't see people who come to me and they wouldn't submit themselves to a 5-hour glucose tolerance just for curiosity's sake. So my hit rate was very high. I would say probably in the high 90% that there was something wrong.
Wow, yeah. But again, you were dealing with people with tinnitus, with
tinnitus, dizziness,
and that's where the canary comes in.
Hearing loss, yes.
So they're coming up in the 90s.
Yeah, and I was seeing this, and I actually had a few patients that became type 1 diabetics. I do a glucose tolerance initially, and 2 years later they're type 1 diabetics. So what I really found out is they just knocked out their pancreas.
Yes.
And then the other thing, I think that the worst thing that's going on in medicine today is physicians, even endocrinologists, who are looking after people with type 2 diabetes, and they're having trouble controlling their blood sugar because the patient's not compliant with the diet, the lifestyle, etc. So they're giving them insulin to control their blood sugar. I can't believe this. And these are, quote, knowledgeable people.
They are, yeah. There's
supposedly. Well, you saw what you ran into when you first started looking.
That is just incredible. Dr. Jason Fung is a nephrologist, and I was over in South Africa at the Low Carb Conference. He had around 20 guys there, experts. Jason Fung gave amazing lectures, but he has won the 2 lies of type 2 diabetes. And one is that it's a chronic progressive disease. No, it doesn't have to be at all.
Right.
You're fueling it with the carbohydrate stimulus. To people who are essentially carbohydrate intolerant, you're fueling it. The Diabetes Association say a high carb, low fat. Right, so that's what. And then using insulin. That insulin will be needed and is good to control blood sugar. Complete lie. So what I tried to write it there.
I saw you say that in there.
Yeah, you're giving
fuel
the primary root cause, excessive glucose, you're feeding them, you're promoting. Right. And then the secondary root cause, which is insulin, inherently kind of pathological, you're giving them that. It's just, but there's huge money in the insulin. The insulin price, I'm not sure you're aware, the last few years has rocketed.
Oh, really?
Yeah, they've changed formulations, they've jacked the price up. It was in Medscape. And I think part of it is as patents run out, you've got to get your revenue elsewhere. So they've got a captive audience with insulin. So there's a big furore around why it was going up. It's 100 years old. They've new, slower release, but they're basically using their grip on the market, 3 companies, and the price has gotten where people now have to actually try and budget for insulin,
Wow.
So but this is just part of the whole craziness.
Oh yes.
And type 2 diabetes, Dr. Jason Fung, generally, not 100%, but people who are compliant, you can have them off insulin, people on 300 units even, have them off insulin in 4 to 6 weeks. And he showed the insulin curves for a whole smattering of patients.
So
insulin.
So in my case, I would my first look at an effective treatment is in 3 months. So my patients with abnormal 5-hour tests come back with a 2-hour test, and I compare the numbers to what they were on the original 5-hour test, looking especially to see what happens to that 2nd-hour insulin.
Yes,
so I could tell about dietary compliance with it, and then I would keep following those 2-hour glucose tolerance tests with subsequent visits until they were normal.
And they are normalising back to kind of a pattern 1 essentially. Well, okay, you've got the 2-hour test as a proxy.
Right.
And you know how to read it and know what's normal. And is that that was the thing that Dr. Kraft actually, even though I have a 1978 photocopy of a patient where he shows on a low carbohydrate regime how the response completely changed, and then how they could be pattern 5 then they come up. But when I asked him about like low carbohydrate, I'm in a movement now, that's the low carbohydrate movement. But I wondered, did he believe that that's essentially the way to go broadly? And he said, oh, well, you know, dietary and nutrition, that wouldn't be my thing. He kind of backed off from that. But the
nutritionist I work with, and that doctor has since retired, but there's still one practicing here in New York, and if you want to get hold of her, you can use my name. I'm sure she'd be happy to speak to you. But the diet basically consisted of 3 meals a day with 3 interval snacks.
Okay.
And the purpose of which was to maintain the blood sugar between the meals.
Okay, stabilizing blood sugar.
And it was depending on the patient's needs and the need to lose weight, it could be calorie restricted or not,
right,
for weight loss. And it took out all the simple carbohydrates were removed.
Okay, so that's key of it.
Yeah, and I don't know, because I didn't get to read everything. Did you focus on high fructose corn syrup in processed foods and all the other kinds of things? Because that's part of it, and part of the insulin resistance group shows a map of the world. And the incidence of this, because it's occurring all around the world, and related to high fructose corn syrup, partly as one of the major parts of all of this.
Absolutely, fructose acting on the liver, causing the insulin resistance. Yeah, it's in chapter 6 actually, the metabolic syndrome.
Right.
Now, some readers said, well, you know, this is great. Chapter 5 is amazing stuff, but then chapter 6 there's a certain amount of duplication. But it's hard not to, because metabolic syndrome is the insulin resistance syndrome.
Well, I think your purpose of writing this book is for the public, correct?
Yes.
So you can't not say things more than once.
I mean, it's a trade-off. So we're aiming for a really kind of racy read that's populist, and obviously I've got to pull some punches there on mechanisms. And you're right, you absolutely have to repeat, but you want to keep it as readable as possible. It depends on I have teachers, lecturers, doctors, researchers, and kind of average normal person in the team who are reviewing it. So I'm continually correcting. But yeah, I'll strike the balance. But I certainly give several pages on fructose in the metabolic syndrome as a primary root cause. And I have diagrams. I'll send you the whole thing. I just didn't want to be sending the whole book. But I have diagrams showing insulin and appetite enhancement loops, and also showing where fructose comes into the liver, and then where high carbohydrate comes through hyperinsulinemia, and then fructose into the liver then is enhancing the insulin resistance cycle. And I go through the fruity fanatics and the fructophobes, because there are two camps. There are people out there who defend fructose, true fruit, and even in general, there's biochemists and a professor who's really good who kind of defend fructose when it's not in huge amounts. And then there's another camp that basically is a no fructose camp.
Right.
No need, don't take any if it's too much.
Right. Well, so the nutritionist then gets people to start to read labels.
Right.
Okay, so if any of this appears in the first 3, you can't have it.
Yeah.
So the patients end up going into the supermarket, and before they buy anything, they read the contents. So any of those maltodextrin and all those other things have to end up way at the other end.
Yes.
If they're in the first 3, you can't have it, and better not to even have it if it's on the label at all.
And there's all the synonyms, like you say, there's around 40 different ones, and they split it up.
Oh yeah, yes,
It's evil.
Yeah, right.
Yeah, so fructose, a huge thing. And then balancing, to keep the blood sugar stable, fructose and the sugar, simple sugars all taken out. And what about the kind of more complex carbohydrates? Do they say
more for the so they stress the complex carbohydrate. Like a snack, an interval snack could be a few peanuts and some raisins. So you have some protein and some fruit sugar basically in between.
Okay. And why? But this is why the fruit sugar? Why not just the peanuts? Why not back the sugar off completely?
Well, you'll have to ask them. Same thing, right?
Yeah.
Same thing. That's outside my bailiwick. Although my daughter's actually a nutritionist, and so.
Well, this is it's a current debate. Generally out there, as in low carbohydrate, meaning minimal, like 50 grams or less a day, or whether some is good. But for diabetics, I suppose most people in my network would generally say no, just low carbohydrate. Some people go further ketogenic, go so low in carbohydrate that you're in a state of ketosis nearly all the time.
Right.
I think that's a little too hardcore on the other side. So but fasting as well. Dr. Jason Fung has in stuff from the turn of the century, Jocelyn, where fasting, I think he had a quote from him, I had it in one of my seminars, where he said within a couple of years fasting will be acknowledged as the treatment for diabetes. Actual fasting.
Well, right. So I don't know if you're familiar with the Life Extension Foundation.
I've come across them. Yeah.
Okay, so they're recommending that if your fasting blood sugar is higher than, I can't remember, 90 or 95, you're in trouble.
Yes, I put the figure 95 in the book, and I just had to scratch my chin and say, what figure will I pick? And I picked 95.
Yeah, right.
That was my sense from all the data.
Right.
85 is best.
Yeah.
And really low readings can indicate a problem too.
Right.
Yeah.
And then the other thing that I had trouble with initially when I first started seeing these patients, I'd see these normal cholesterols but high triglycerides, and I see my fellow doctors putting them on statins, but statins don't work on triglycerides.
No, they don't.
Because the triglycerides are a direct thing from the intake of carbohydrates.
Exactly. And there may be a promotion as well of diabetes, ironically, with the statins. There's quite a bit coming out about that. Yeah, well, the diet thing, I think that'll be played out in the next 10 years. It would appear that for diabetics, I don't think it's a cure per se, but the essential reversal of diabetes with low carbohydrate seems to be nearly universal.
So what's his name? He practiced here. He's a famous guy. He slipped on the ice and died.
Oh, Atkins.
So Atkins and I were in the same. We were practicing in Manhattan, right? So
he was irascible, though, wasn't he? He was. He didn't do himself any favors. He was meteor. I had dinner last night with a lawyer who had an MI last year. Found my cholesterol conundrum, and he just thinks, he thought it was fantastic because it explained to him how it all worked, gave him confidence. But he was a lawyer in Atkins' team way back. And he got to kind of hear all the Atkins. He even thought he was kind of doing Atkins. And then he was diabetic type 2. So he's Cuban extraction. So, those people are very prone. And even though he thought, with his connections to Atkins and representing him, he thought he was doing the lower carb thing. He wasn't really. Became diabetic. HbA1c was up at 6.5 or so. He was told that that's fine. Under 7 is great.
The other thing
until he had a heart attack.
So and so my conundrum now is that I'm planning to introduce this concept, and that their systems are such you can't get a 5-hour glucose tolerance test.
It's such an amazing.
And then part of it is the financing of it, the cost of everything. So I actually, when I was speaking to Joe, because I was in contact with him also with this New Zealand person.
Professor Brandt, and there's a lady there, yeah.
So I said to him, Joe, I may be setting up a new system, and what do you think? I think I can get a 2-hour glucose tolerance test with simultaneous insulins, and how would it be if I put it together with the hemoglobin A1C, at least to figure out where I am with these patients, because I know I can't get the 5-hour on them. Because when I had the 5 hours, I understood the mechanism of what was going on in their ears. It was all very clear to me, and there's a possibility that if I actually start getting back in practice in Arizona, to look after these patients, and I'm planning to set up like a tinnitus center and a dizziness center within the ear, nose, and throat department there. And then I also have already met with the migraine neurologist that's there, and she is interested in the whole vestibular component. So I actually I'll send you. I wrote a column for one of the journals. So I had a childhood friend of mine called me. I'm originally from Canada, Winnipeg. Oh, so a childhood friend of mine calls me one December from Winnipeg saying he had a sudden hearing loss in one ear. What should he do? So I said, well, so are you seeing somebody else? Okay, I said, you're getting standard of treatment. Let me know what's going on. And like a lot of people in our age group, when it gets to December in Winnipeg, they went to Hawaii where they spent the winter. So he calls me a month later. He said, my hearing's back. I said, great. If you're ever in New York, come by. I'd like to check you out. So it turns out I had a son living here at the time. So it turns out the following June he comes by. And so I take a history from him. And it turns out that he's got a 30-year history of migraine, and he's taking triptans, the drugs for migraine. He's taking as many as 15 a month for what he calls wall banger headaches, where you bang his head against the wall because they're so bad. So I do a hearing test. It's hearing. Yeah, your hearing is good. Both ears, there's no problem. But part of my exam is to examine the balance system and all the other things. I said, I have some kind of an interest in headaches that could be coming from the inner ear. Do you want to explore that? He said, sure. So we worked him up, and he had the softening of the bone around the inner ear. Well, I can do that with special CAT scans of the bone around the inner ear, so I can actually see it. See the bone change.
Excellent.
You can see the bone change. And he had an abnormal glucose tolerance test. And so we put him on a diet to address the blood sugars. I can't remember what his insulins were. And we put him on the medications that are focused on osteoclasts. They turns them off. So within 6 months, he was taking, can't recall exactly, 6 of those or 7 triptans a month as opposed to 15.
Okay. And
within 2 years, he was headache free.
Wow.
And then he'd periodically come to New York, and I'd check him out. And towards the end, I saw he was actually vitamin D deficient. I didn't know originally. Okay, so we got him on vitamin D, and he's remained headache-free. It turns out that he actually has some osteoporosis, and so his doctor in Winnipeg was really happy, because I have trouble getting the regular doctors to understand why they need to be on these drugs for osteoclasts when they don't have osteoporosis. But it was easy in his case, and so we reversed his vitamin D stuff. So. And then the other part is that from about 1999, I had an electronic health record. So I would have a whole set of things I'd ask patients. So if on the original visit a patient's listed headaches, although they're coming to me because they're dizzy or something else, I would just put headache. And as I would put them on treatment, I'd say, what's happened to your headaches? Oh, well, they disappeared as my dizziness went away or something like that. And so I had this whole thing on not necessarily migraine, just headaches in general. So, so all that stuff.
And he had did you say a 30-year history before that?
I think so. I wrote it up. I'll make a note to send you, because they ended up as like one-page things in a journal that I wrote a column for each month. And so what I'll do is I'll find it, and I'll send you the actual thing, because I'm just doing this off the top of my head, but.
Oh no, this is fantastic, and it really is just tough. It just occurs to me, if one resolves insulin resistance to the satisfaction of achieving pattern 1 consistently, I mean a perfect response, and your vitamin D is ensured to be a very healthy evolutionary level, I know, let's say around 35.
Oh no. Has to be at least 40 to 50.
Are you talking nanomoles or nanograms?
I'm talking about, I don't know how it's reported here.
What would be, well, in nanomoles below 50 is deficient, but that's below 20 nanograms is deficient.
Okay, so the labs here put down usually less than 20 is vitamin D deficiency.
That's nanograms.
Okay, 30 might be vitamin insufficiency.
Insufficiency, yeah.
Okay, so there's a group I belong to here called the New York Metropolitan Bone Club.
Okay, yeah.
So it's a group of doctors who look after bone disorders. I'm the only ear doctor in the group.
Okay.
And I actually haven't been to the meetings in a while. So what happens is, there are 5 medical schools here in New York City. So what happens is all of these international experts and experts from around the country come to teach at the different medical schools. So when they come, the group sets up an evening dinner, with desserts, I might say.
Old.
Because they're bone people. And we get lectures. We have had guys from Oxford, another guy from Australia, the guy who set up the parameters, what's called the DEXA scan, and I found out what's wrong with it. As an engineer, you'd really be interested to know what the variables are on that, which are amazing. So in sitting around the table with these guys who are looking after patients every day, looking at them only as bone problems. So the answer is it should be between 40 and 50.
40 and 50, yeah, and it is nanograms from what you described. My target for myself is 45.
Yeah.
And I'm coy about it because when I gave the seminar, I had to make a choice. There are people out there, learned people, who would want to be really up at 60, that kind of level.
And the Life Extension Foundation is recommending 5,000 international units a day.
Now, I did say when I gave the seminar, a few thousand, I didn't want to get too, prescribing. I said a few thousand. I explained that the toxicity belief is completely unfounded, that up to 10,000 a day is certainly not a problem, and the best data indicates up to 30,000 a day. Beyond that, you've got the toxicity. There's a toxicity. Now, I wouldn't...
Yeah, but there's also another thing. There's vitamin D2, which doesn't work as well. So what the doctors here do, the endocrinologists, is when they first make the diagnosis, they give a shot of 250,000 or something.
It's insane.
And vitamin D2 doesn't work as well. But
Yeah, and I don't know if you're familiar with Professor Hollis. He's incredible stuff on YouTube, and I use some of his material. D3 has a half-life of around 1 day. So whatever about the 25-hydroxy, which has a storage potential, the D3, his thesis largely is it should be coming in on a daily basis steadily, because the D3 in itself is an active agent.
Right.
But you're right, and not D2.
Right.
So then Professor Hollick, who's Mr. Discoverer of the D, did work to say D2 and D3 are not that different, but it's a whole field in itself. But the 45, I reckon I'm at 42. I didn't get a measurement in my life until 2 months ago, and I'd spent the previous year between sun exposure and a vitamin D lamp, not so much supplementation. I was targeting through instinct 40 to 45, so I got 42, and my wife got 43.
Okay, so one of the guys that spoke to the Bone Club, he's a bone guy who's in Maine. Right. So he took his whole crew to Hawaii, and he measured the vitamin D levels on lifeguards and surfers who get 11 hours of sunshine a day, and most of their body is exposed to the sun. Absolutely. Right? They're very brief outfits they wear. And I think he found, I can't recall the exact number, somewhere between 20 and 40% were vitamin D deficient.
Oh wow, that's sun creams they're using, are they?
Well, it could be. It could be, and of course the other. Then the other part is with high melanin. So in the black population, they're not the effect of sun on them is. So a lot of them are vitamin D deficient, and so when you look at pregnancy, there's a factor in there as well with regard to vitamin D deficiency in the black population, which is a whole other issue.
A whole question, yeah, for sure. But I'm surprised at our kind of lifeguard type. You would think they would, because
yes, and I think the lifeguards in general, from what I've seen of most of them, they don't really wear any sunblock.
No,
because they get tanned up enough that
they do. Yeah.
But nevertheless. It was, I couldn't believe it.
It's bizarre. The best is, I think, dermatologists, 95% of dermatologists, I believe, in Australia are very vitamin D deficient, because they, of course, believe in hiding from the sun.
Right.
So that's, the whole vitamin D. Now, Chris Masterjohn, his PhD, has done a lot of talks about this, and he talks about the vitamin D and being really too high could have a negative consequence, especially if you're low in K2. I suppose there's possible room for that, but 45 would appear to be the target.
Yeah, like I said, between 40 and 50.
Exactly.
Exactly.
Vitamin D. There's so much in that. And if one got one's insulin resistance, as we were saying a few minutes ago, down to basically the floor, and Dr. Kraft actually also noted several times in his life, even though he's so aware of this, he slipped into diabetes in situ, and he dissociated with he might have drifted 7 to 10 pounds in weight up. He didn't seem to focus so much on the carbohydrate content in his diet, but he could slip in and out.
Right.
Even though he's so aware. But if one was aware enough to never be insulin resistant, and if you tie that in with some Ivor studies and the connection to mortality and disease, myriad diseases, and your vitamin D is kept up at 45, ideally through healthy sun exposure, and your K2 is up through the appropriate foodstuffs. And what else do we make? What are the other key? Your omega-3, which is another whole axis. Which, if all those things are optimized, one would wonder the need for medications, even the osteo medications, would possibly relatively rare cases that would not respond to all of those vectors together.
Right. Well, so the bone related ones, the ones that go after the osteoclast, I think you just have to turn off the inflammation part, which is the trigger, because that's basically the effect is the macrophage becoming an osteoclast.
Yeah, the underlying driver. Switch that off. Yeah.
Yeah.
Yeah, that's a pretty huge thing to say that, because for most people the information with the knowledge that you've discussed so
those things I showed you in here, those cells have hormone receptors on them as well, and that's why the female part and osteoporosis with the menopause is partly related to the hormone receptor on the osteocyte. So they have a mechanoreceptor on there. So the mechanoreceptor on there is there to give strength to the bone.
Right.
Okay, so it measures what the bone, this is for skeletal bone. We know nothing about the ear bone. Well, that's the thing I'm going to be exploring with my new colleague. But the mechanoreceptors give the osteocyte information about what's needed for the strength of the bone to do its job. And the osteocyte can kill itself, or it can recruit osteoblasts, so it can actually change the strength of the bone. So this bone, skeletal bone, undergoes a change every 7 to 10 years. So the bone, you get a new bone every 7 to 10 years. The inner ear is between 55 and 70 years.
Wow.
And
slow response.
There's a whole, and so I'm looking forward to getting into this with so we have some research projects we're actually going to be starting on this week, actually, looking at bones of genetically produced mice that affect the bone around the inner ear. So you're going to be looking at that, actually.
That's going to be fascinating. And the the weight bearing, of course, that's where weight bearing exercise translates and is sensed and flexing, I suppose, or whatever way it's sensed.
Except for astronauts. So the astronauts have pedal like this, You know, they have 6 hours a day on this, and they're given these drugs to prevent, to reduce, and they still come back with osteoporosis. So that's the problem I'm working on as well.
So the lack of gravity, you can't overcome it, but by weight bearing and all that, it won't make the system respond.
Yes, they still have their osteoporosis. And so I don't know, you know, the Kelly twins, you're familiar with them? The one who's married to, they're two astronauts, they're identical twins. And one was married to this woman who got shot in Tucson, this congresswoman, Kathy Gifford? Well, in any event, so they're both astronauts. So they just sent up, one twin is going up has gone up, he's been up there now maybe about 30 days to the International Space Station, and he's going to be there for a year. Okay, and his twin brother is going to be down on Earth, and they're going to measure what their differences are going forward. And so so I got interested in what's called PRAL, potential renal acid load, and how it affects your loss of phosphorus through your kidneys. And so through my aerospace guy, we had a conference call with the Johnson Space Center in January, because I said, you know, I think part of the osteoporosis thing with the astronauts is related to their diet, and this thing called PRAL, potential renal acid load, and so, but it turns out that it's really hard to. The astronauts are kind of like a protected group, and it's really hard to get things out. I said, all I really want is a diet diary and some urine every day, and then they got these shuttles going up and back where you can get back and test them. And so they may be thinking about it, or they actually asked us to present a grant request to do that. But I'm going to wait and see what comes back with this guy with his osteoporosis.
That's great. Yeah, it's not often you get an experiment like that where you can have twins in just the right places. Oh, we were saying if all these elements were addressed, well, it's the $1 million question probably. But if inflammation underlies so much of it through so many mechanisms.
Right, and your cancer thing in there, because I caught that part, is probably partly related to that. So I'm really glad that whoever this person is that's supporting you to do this wants to really bring this out. I think it's really great. And I think an informed public could push the medical profession to do things differently going forward.
That's his intention, and the same with the awareness of the CAC. The cardiologists largely have rejected it. I mean, largely speaking, even though it is in the 2013 guidelines now as evidence that it is useful for middle risk people, but no one really knows about it. It's just gathering dust in the guidelines. But he felt, he won't get progress with cardiologists. The way to do it is democratize it, let it become a discussion. Right. And then the pressure will come back. It's just the only way. Really. Right, exactly, and that's where I didn't realize they were the incorrect guys. Okay, so and I think Dr. Kraft travelled over there and he worked with them, and he said it was a blast. And
I actually first personally met him in Bad Kissinger. Actually.
Oh, okay, that's the action. So it appears then that there's these centres of the kind of correct science.
Centers of enlightenment.
Enlightenment, perfect. That's much better than correct science. Centers of enlightenment.
Yeah, everybody's crazy except us.
But if you think about it, you've got on the... That's exactly it. And the problem is whenever you're in a club or a group that believes one thing, you've got your own confirmation bias.
Right.
And that's why I've always myself, I know I'm in a worldwide low carb movement, I always thinking, are we missing something here? Is there a kind of black swan that says, hold on, it's not as we think? I've yet to find, I even created a directory a year and a half ago when I was studying this called Fat is Bad. And in that directory, because I have mountains of papers now archived, but in that directory I would put any credible studies that indicate maybe I'm not completely correct, to try and be my old devil. But no, that directory hasn't been filled. There are studies, but when you go through them, they're not really credible. They're badly designed. Like the vitamin D, 300,000 units given into old people once a year.
Yeah, right.
They said,
and it's D2.
It's D2, yeah. And I think one of them went as hard as 500,000
yes.
on a component that has a half-life in the blood of 1 day. You
but,
get
but if it gets into the fat, it's a fat-soluble vitamin. But if it gets
if you put 500,000 in one day, once per year, how much gets converted? There's no data in the study. Huge study, runs for years, looks at old elderly people, finds it doesn't give an improvement, and then they showed that you could see in the graph, after this massive bolus, in the following month, there was actually an increase in falls and related problems. Right, if any, and then it was kind of leveling out. But it's an absurd test to give something that evolutionary you're getting daily. The half-life of the active component is 1 day, that's fine. It does convert, but you're not even sure about all that, how it works. They're not even sure, they don't even talk about it. Why do you pick 500,000 once a year? It's absurd.
Right.
It's insane.
Yes.
And then you don't get a result, and you scream, look, vitamin D, it's irrelevant. That's what the report screamed. It was almost like they wanted to just wipe it off the table. Anyway, sorry, there's a rant there. But yeah, it's, in terms of enlightenment, there is no question now, if you triangulate all of what you've mentioned and then the rest, triangulate insulin resistance and inflammation between all these different conditions, at the end of the day, it's compelling. There is no escape from it. The primary thing for human population health, the Pareto principle, is focus on the big things, you know, the 20% that have the biggest effect. It screams that insulin resistance should just be the primary focus of healthcare.
Right. And so you use the term metabolic syndrome, but my understanding is that that's no longer used, and in its place is insulin resistance.
Yeah, the insulin resistance syndrome, the metabolic syndrome, syndrome X.
Yeah, it was first syndrome X, right?
Yeah.
Yeah, that's when I first looked at it, when it was called syndrome X. Because I was doing these complete lab work in addition to the 5-hour test, and I'd see these high triglycerides. Okay, and I said, okay, you have syndrome X. You know, then it became metabolic syndrome. Then it became the insulin resistance syndrome, which I think is the more accurate term for it rather than metabolic. And actually, by using that term instead of metabolic syndrome, you're focusing on the problem.
True.
As opposed to a layperson, what does metabolic mean? Yeah.
Actually, that's a good point. I actually use a play on words at the end when I introduce it. It's the start of chapter 6, the metabolic. The reason I used it is because it seemed to be widely used when I came across it first.
It could. Well, maybe it's because of my focus that I think it should just be called the insulin resistance syndrome. It could be that throughout the world there's still a holdover from that.
I think that might be it. At the very start of the next chapter, that's exactly what I do. I say there is another name for metabolic syndrome. I used it because it seemed to be the broadly used one, but then I kind of artfully, hopefully, say there is another name, and unsurprisingly, I put in bold, it's insulin resistance syndrome.
Because I had this guy who talked, when you're giving a talk, the first thing you say is you can tell people what you're going to tell them, and then in your talk you tell them what it is, and at the end of the talk you tell them what you told them.
Yeah, so recap.
So the question is, in terms of that chapter, maybe a more appropriate thing is to say insulin resistance syndrome formerly the metabolic syndrome.
You know what, I think you're absolutely correct. And you know what, when you go into metabolic syndrome, there was some slight feedback there's similar stuff in here. And it might even help in that vector that there is the insulin chapter, which in fairness brings in a bit of evolutionary and the diabetes and all. You need to get through that, and you need to shock people with the figures. Like 7x the heart disease for diabetes. I mean, come on, an engineer goes in, you've got a quality problem. You find a subclass of parts that have 7x the fail rate, you're practically there. And the only thing is with Dr. Kraft and your work is the rest of them just have a lower level. But anyway, sorry, digress. So insulin, largely maybe as it is, and then insulin resistance syndrome, at least the person coming in knows it's connected, it connected. And also it makes 2 chapters of the book essentially have the name insulin, which is deserved because the only thing I worried about the book as well was I'm attributing so much to insulin with Reeven's work, Kraft's work, it's almost like, oh, come on, guy, you're telling us there's one magic cause.
Well, but it is. But it's really when you basically bring it all down the common denominator is lifestyle. So so is it lifestyle as it affects your insulin?
Oh, I agree totally. Lifestyle is what, like, there will not be many people who are genetically insulin resistant and regardless of any lifestyle will just have to live with it. I mean, they try and make that message, oh, well, you know, genetic factors. At the end of the day, how many humans are there that a properly tailored lifestyle wouldn't resolve their insulin resistance? Right. You know, this is going to be time.
And then the genes have a way of actually changing based on your lifestyle, on environment.
Genetic expression, absolutely. And you go into your DNA and you transcript. Even when you switch to a low carb diet, it takes a few weeks to adapt, and you're literally transcripting off enzymes that you now need more of. It's fascinating. But if you put in, I struggle a little. All of the data that I can credibly gather would say Pareto principle, largely insulin resistance is driving most MIs and a lot of cancer and, to be honest, a lot of diseases in modernity. But a lot of people will think, well, hold on, one broad cause. It just seems like it can't be just one thing. And yet even Dr. Thomas Dayspring, the lipidologist, who has honorariums from myriad pharmaceutical companies, and he pushes statins for a high LDL particle count, even though arguably if you're not insulin resistant, a high LDL particle count, there is data to say it's not actually a risk factor. It's only a correlational risk factor. But even he publicly, and I kept it on Twitter, said to me, yes, he said, the majority of MIs are caused by insulin resistance. Even he, who is on kind of on the other side. And yet, it's just it's shocking that insulin resistance is not common knowledge to doctors as the primary thing to work on. It's crazy.
Right.
So
I would suggest finding that Peter Grant, because he does the mechanism of the MI. He ties it all together, and I think that might be of interest to you because it tracks back to insulin and the body's mechanism to basically protect itself in producing the obstruction of the artery.
Yeah, and I will, and I've gone through it, but probably around a year ago. And also there's insulin receptors in the endothelium and macrophage, and the whole thing is tied together. I will certainly follow up, and I'm just thinking where the time is. The other thing is the omega-3, omega-6 axis.
Yeah, that one I'm not as familiar with.
I'll send you the whole version of the book, and time permitting you can glance through and see what you think. But omega-3 is really important, but there are those that would say one of the reasons for the rampant heart disease and all the afflictions in America, like through the 40s and 50s, obviously smoking was a huge factor. They didn't know at the time. Right. So they blamed fat, but really there were smoking was a lot of it, they just didn't know. The other thing is the ingestion of omega-6 fats, the linoleic acid, has gone from evolutionary, you had omega-3, omega-6 are essential fats, you need them because you can't create them in the human body, and they're a ratio of 1-to-1, very low levels. But in America in the last century and around the world, the intake of omega-6 has gone to 200 times the physiological needs. The omega-3 has fallen hugely over the century. The Japanese still have high omega-3, but in America it's really low. And there is an argument and data to say if you're too high in omega-6, then taking extra omega-3 won't actually even really help, because it competes for the same enzymes that convert into the active agents, the EPA and the DHA that go in your cellular, the phospholipid structure. So long story short, and we won't get into it here, there is an argument and data, and the chapter 7 goes into it, that omega-3 index, measuring the cellular content of your omega-3 type, EPA, DHA, in itself is a huge factor in heart disease. So now you've got arguably insulin resistance, which could be argued to be the majority factor, and you've got omega-3 index, which a whole worldwide team are connected, and I mean they're making advances, which is very compelling as a huge driver, and the reason why the Japanese are so low in heart disease. So you've got two huge drivers, which each could arguably add up to more than 100%, and it's the inflammatory same mechanism. If the omega-3 is low in the cellular content, all your 30 trillion cells low in that, and the cellular content of omega-6 will be a pro-inflammatory state. You need omega-6 in small amounts because it actively partakes in inflammatory reactions. You get wounded, infection. You need omega-3, which is anti-inflammatory through myriad mechanisms. And the balance seems to be, you're okay, an 8% to 11% omega-3 content in your cellular structure. Americans average below 4%. And there's a critical nexus there that the risk goes through the roof if you drop down below 8. Northern Europe is 5.5, America's 4. Anyway, sorry, that was a long blast, but...
Okay, well, you're going to make me look it up now.
Well, it'd be interesting.
I'm on PubMed every day, so I do literature searches every day.
Well, I'll send you on. But just, I think you'd be interested to see what you think. But the book is as it is. I'm going to be largely saying insulin resistance is the overwhelming driver, but I have to acknowledge
influences of other things, comorbidities.
Yes, an underlying pathological state.
Right.
And I'll lay it out. I have to do the omega-3, omega-6. I'm going to do a chapter then that kind of covers much more briefly everything else, and that's where vitamin D comes in, and K2 and magnesium. I think magnesium, 75% of Americans, I've seen some data, are kind of deficient in magnesium.
Well, nobody really knows because it's stored in tissue. Serum magnesium is not accurate.
Yes.
And the next closest thing is a red blood cell magnesium, and it also isn't exactly perfect. If you look at magnesium in the soil in the world, you see it's diminishing.
Yes.
And the farmers in their crops aren't adding magnesium, so that the new organic foods or crops of it where magnesium could come from isn't there. So there's also a nutritional deficiency of magnesium, and that's all hooked into bone. And while parathyroid hormone is considered a sensing hormone for calcium, there's literature that magnesium can also cause the parathyroid hormone to go up,
right?
Which can then cause a loss of bone.
Yeah, so it's tied in multiple ways, really.
Yes.
Magnesium.
Yes.
Yeah. It's. I'll mention it at a high level to cover it. And a vitamin D chapter I've written, but to be honest, there's too much, I think, in the book already to be a populous book. So I've written around 10,000 words. Yeah. I'm going to back off and just do a segment on vitamin D with the highlights.
Well, you have to make it readable for the general public, and you can't, as much as you know, and as much as you would like to impart that information to the readers, you can overwhelm them, and then there could be a problem.
And yeah, they on the one hand, while the message is a little bit, it might appear too simplistic, but hopefully the data, the studies and the engineering slant will give it the impact.
Right.
But to say it's primarily insulin resistance and omega-3, omega-6 is a huge deal. Yeah, I think after that you can't do a big long diatribe on vitamin D and another one on, because then at that stage it's becoming like there's all of these things.
Right.
It has to be kept simpler, yeah. Let's see.
Well, really great. Happy to have met you.
Super, and I'm delighted. I'm honored.
I think you're terrific. I think what you're doing is great.
Well, I don't have all...
As an engineer even, I love it. I love it.
I'm delighted, yeah. Dr. Kraft seemed delighted too.